Welcome to the Dr. Izzy's Medical Podcast channel.
Leukocytosis. Leukocytosis is a condition in which the white cell is above the normal range in the blood. It is frequently a sign of an inflammatory response, most commonly the result of infection, but may also occur following certain parasitic infections or bone tumors as well as leukemia. It may also occur after strenuous exercise, convulsions such as epilepsy, emotional stress, pregnancy and labor, anesthesia as a side effect of medication, and epinephrine administration. There are 5 principal types of leukocytosis. Neutrophilia, it is the most common form. Others are lymphocytosis, monocytosis, eosinophilia, basophilia. First, neutrophilia leukocytosis. Neutrophilia is leukocytosis of neutrophils, that is, a high number of neutrophils in the blood. Because neutrophils are the main type of granulocytes, mentions of granulocytosis often overlap in meaning with neutrophilia. The opposite of neutrophilia is neutropenia. Causes: neutrophils are the primary white blood cells that respond to a bacterial infection, so the most common cause of neutrophilia is a bacterial infection, especially pyogenic infections. Neutrophils are also increased in any acute inflammation, so will be raised after a heart attack, other infarct or burns. Some drugs, such as prednisone, have the same effect as cortisol and adrenaline, causing marginated neutrophils to enter the bloodstream. A neutrophilia might also be the result of a malignancy. Chronic myelogenous leukemia is a disease where the blood cells proliferate out of control. These cells may be neutrophils. Neutrophilia can also be caused by appendicitis and splenectomy. Primary neutrophilia can additionally be a result of leukocyte adhesion deficiency. Second, lymphocytosis leukocytosis. Lymphocytosis is an increase in the number or proportion of lymphocytes in the blood. Absolute lymphocytosis is the condition where there is an increase in the lymphocyte count beyond the normal range, while relative lymphocytosis refers to the condition where the proportion of lymphocytes relative to white blood cell count is above the normal range. In adults, absolute lymphocytosis is present when the lymphocyte count is greater than 4,000 per microliter, in older children greater than 7,000 per microliter, and in infants greater than 9,000 per microliter. Lymphocytes normally represent 20% to 40% of circulating white blood cells. When the percentage of lymphocytes exceeds 40%, it is recognized as relative lymphocytosis. Causes: lymphocytosis is a feature of infection, particularly in children. In the elderly, lymphoproliferative disorders, including chronic lymphocytic leukemia and lymphomas, often present with lymphadenopathy and a lymphocytosis. Causes of absolute lymphocytosis include acute viral infections, such as infectious mononucleosis, hepatitis and cytomegalovirus infection. Other acute infections such as pertussis. Some protozoal infections, such as toxoplasmosis and American trypanosomiasis. Chronic intracellular bacterial infections such as tuberculosis or brucellosis. Chronic lymphocytic leukemia. Acute lymphoblastic leukemia. Lymphoma. Post-splenectomy state. CARD11-related congenital B-cell lymphocytosis, rare, also known as Bennett disease. Causes of relative lymphocytosis include age less than 2 years, acute viral infections, connective tissue diseases, thyrotoxicosis, Addison's disease, splenomegaly with splenic sequestration of granulocytes. Diagnosis. Lymphocytosis is usually detected when a complete blood count is obtained. If not provided, the lymphocyte count can be calculated by multiplying the total white blood cell count by the percentage of lymphocytes found in the differential count. The lymphocyte count can also be directly measured by flow cytometry. Third, monocytosis leukocytosis. Monocytosis is an increase in the number of monocytes circulating in the blood. Monocytes are white blood cells that give rise to macrophages and dendritic cells in the immune system. In humans, monocytosis occurs when there is a sustained rise in monocyte counts greater than 800 cubic millimeter to 1000 cubic millimeter. Monocytosis has sometimes been called mononucleosis, but that name is usually reserved specifically for infectious mononucleosis. Causes. Monocytosis often occurs during chronic inflammation. Diseases that produce such a chronic inflammatory state. Infections: tuberculosis, brucellosis, listeriosis, subacute bacterial endocarditis, syphilis, and other viral infections, and many protozoal and rickettsial infections. Blood and immune causes: chronic neutropenia and myeloproliferative disorders. Autoimmune diseases and vasculitis, systemic lupus erythematosus, rheumatoid arthritis and inflammatory bowel disease. Malignancies: Hodgkin's disease, and certain leukemias, such as chronic myelomonocytic leukemia and monocytic leukemia. Recovery phase of neutropenia or an acute infection. Obesity. Miscellaneous causes, sarcoidosis and lipid storage disease. During these stages of extreme inflammation, monocytosis can damage tissues because it increases the activation of the immune response and prevents the inflammation from subsiding, which is seen in cases where sepsis occurs. Diagnosis of monocytosis. Leukocytosis. Blood test, normal range of monocytes, 1 to 10%, normal range in males, 0.2 to 0.8 times 10 to the power of 3 microliter. Blood test checking for monocytosis, abnormal ranges, greater than 10%, abnormal range in males, greater than 0.8 times 10 to the power of 3 microliter. Treatment of monocytosis. Ceftriaxone if there is typhoid fever and levofloxacin or moxifloxacin. Gentamicin and doxycycline if brucellosis. 4th, eosinophilia. Leukocytosis. Eosinophilia is a condition in which the eosinophil count in the peripheral blood exceeds 500 microliter. Hypereosinophilia is an elevation in an individual's circulating blood eosinophil count above 1,500 microliter. The hypereosinophilic syndrome is a sustained elevation in this count above 1,500 microliter that is also associated with evidence of eosinophil-based tissue injury. Eosinophils usually account for less than 7% of the circulating leukocytes. A marked increase in non-blood tissue eosinophil count noticed upon histopathologic examination is diagnostic for tissue eosinophilia. Several causes are known, with the most common being some form of allergic reaction or parasitic infection. Diagnosis of eosinophilia is via a complete blood count, but diagnostic procedures directed at the underlying cause vary depending on the suspected conditions. An absolute eosinophil count is not generally needed if the complete blood count shows marked eosinophilia. The location of the causal factor can be used to classify eosinophilia into 2 general types: extrinsic, in which the factor lies outside the eosinophil cell lineage, and intrinsic eosinophilia, which denotes etiologies within the eosinophil cell line. Eosinophilia is not a disorder unless it is idiopathic. Diagnosis. Diagnosis is by complete blood count. However, in some cases, a more accurate absolute eosinophil count may be needed. Medical history is taken, with emphasis on travel, allergies and drug use. Specific tests for causative conditions are performed, often including chest X-ray, urinalysis, liver and kidney function tests, and serologic tests for parasitic and connective tissue diseases. The stool is often examined for traces of parasites, though a negative test does not rule out parasitic infection. For example, trichinosis requires a muscle biopsy. Elevated serum B12 or low white blood cell alkaline phosphatase, or leukocytic abnormalities in a peripheral smear indicates a disorder of myeloproliferation. In cases of idiopathic eosinophilia, the patient is followed for complications. A brief trial of corticosteroids can be diagnostic for allergic causes, as the eosinophilia should resolve with suppression of the immune overresponse. Neoplastic disorders are diagnosed through the usual methods, such as bone marrow aspiration and biopsy for the leukemias, MRI-CT to look for solid tumors, and tests for serum LDH and other tumor markers. Treatment for eosinophilia. Leukocytosis. Treatment is directed toward the underlying cause. However, in primary eosinophilia, or if the eosinophil count must be lowered, corticosteroids such as prednisone may be used. However, immune suppression, the mechanism of action of corticosteroids, can be fatal in patients with parasitosis. 5th, basophilia. Leukocytosis. Basophilia is the condition of having greater than 200 basophils microliter in the venous blood. Basophils are the least numerous of the myelogenous cells, and it is rare for their numbers to be abnormally high without changes to other blood components. Rather, basophilia is most often coupled with other white blood cell conditions such as eosinophilia, high levels of eosinophils in the blood. Basophils are easily identifiable by a blue coloration of the granules within each cell, marking them as granulocytes, in addition to segmented nuclei. Causes. Basophilia can be attributed to many causes and is typically not sufficient evidence alone to signify a specific condition when isolated as a finding under microscopic examination. Coupled with other findings, such as abnormal levels of neutrophils, it may suggest the need for additional workup. As an example, additional evidence of left-shifted neutrophilia alongside basophilia indicates a potential likelihood primarily of chronic myeloid leukemia, or an alternate myeloproliferative neoplasm. Additionally, basophilia in the presence of numerous circulating blasts suggests the possibility of acute myeloid leukemia. Elevation of basophils may also be representative of multiple other underlying neoplasms such as polycythemia vera, myelofibrosis, thrombocythemia, or, in rare cases, solid tumors. Alternative root causes other than these neoplasmic complications are most commonly allergic reactions or chronic inflammation related to infections such as tuberculosis, influenza, inflammatory bowel disorder, or an inflammatory autoimmune disease. Chronic hemolytic anemia and infectious diseases such as smallpox also demonstrate elevated basophil levels. Certain drug usage and food ingestion can also correlate with symptoms of basophilia. Treatment. Basophilia, as it is primarily a secondary condition, is treated by addressing the causative disease or disorder. The underlying condition will determine what treatment is appropriate. Specifically in cases of allergic reactions or associated with chronic inflammation, treating the underlying cause is critical to avoid further, potentially irreparable damage to the body's organ systems. Common treatments to allergic reactions include cessation of utilization of the offending agent, and the administration of antihistamines. Infection-related basophilia can be remedied by utilizing antibiotics to treat the underlying causative infection, whereas neoplasm-related basophilia may have a more complicated clinical course including chemotherapy and periodic phlebotomy.
Thank you for listening Dr. Izzy's Medical Podcast Series. If you want to support this project, please subscribe the channel and like this video. Thank you.